So we'll go on to the second talk. We'll have questions after Dr. Gupta's talk. But I want to thank you for that introduction and for reminding our primarily US-based audience that not to obsess over KT over urea. I think that's so important. So thank you again. And we can move on to talk about complications of peritoneal dialysis. Save your questions, put them into the app for the Q&A session after this talk from Dr. Gupta.
Okay, and I just want to vent that I troll a Facebook American PD patients Facebook site, and if you read the comments, it's all about passing or failing their KT over V. And you know, the nurse said to me, I failed my KT over V, and I have to get a dialysis line in my neck, and it just like breaks my heart. So I really, if I could change one thing, it would be to get rid of this obsession with KT over V urea as the one and only marker of adequacy of peritoneal dialysis. Okay, so I'm the same person. I have the same disclosures. And these are the learning objections for the complications. We'll talk about catheter complications, infections, and non-infectious complications. So we're going to start with a fictional poor patient, Ms. Bad Karma, who had postpartum irreversible renal failure, didn't have a donor, and decided to undergo home peritoneal dialysis. And she had an uneventful PD catheter insertion. She comes for training, and the dialysate fluid goes in easily, but there's very slow outflow. The first 500 mils takes about half an hour, which is way too long. It's just sort of drip, 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 and then the flow stops altogether. So this is a common occurrence. It's very disheartening, and it's really important that you have a way to approach this. So catheter-related problems tend to occur right after implantation. It's not impossible, but it's not very common that someone's on PD for like 3 years and all of a sudden they get flow problems. So it's really kind of an early thing that happens. And what you have to say to yourself is, am I dealing with two-way obstruction, which is a problem with inflow and outflow? Or am I dealing just with one-way obstruction, where there's good inflow but poor outflow, like Ms. Karma here? Another problem, which may or may not be related to the catheter, is pain with inflow or pain with outflow. What isn't necessarily a problem is the following. You have a brand new patient who comes in to start PD training. Their belly is empty of PD fluid. The nurse puts in, let's say, 1 liter to start with, and it goes in just fine. And then it's drained, and the fluid comes out just fine, but only half of it comes out. That isn't necessarily a problem, because it may be that some of the other 500 mils has just filled up the dead space inside the peritoneal cavity, like the pericolic gutters or things like that. So it isn't like there's something wrong with the conductivity of the catheter. It's just that the fluid has gone into some spaces where it's not reachable to return in the drain. So all you have to do there is add in more fluid until you have a working volume of fluid that is inflowing and outflowing. Two-way obstruction, nothing's going in and nothing's coming out. That is usually due to some sort of problem with the catheter lumen, a kink or bend in the catheter, or something clogging the lumen of the catheter, such as a hunk of fibrin or a blood clot. And a good experienced PD nurse will do what's called suck and flush under sterile conditions, where they'll use heparinized saline or some sort of brush into the lumen, and under sterile conditions try to clear out the catheter lumen in this two-way obstruction. And here's one of our new start PD patients who had no inflow, and the nurse did suck and flush and was able to suck out this honking piece of fibrin that was filling up the lumen of the PD catheter. And here's a patient that had a catheter dye study. And what you can see here is the dye in the PD catheter. But all of a sudden here, it makes a sharp turn with a block, which is probably due to kinking because of the sharp turn. So I don't know why it kinked, but you can see why there would be problem with inflow in this kind of a scenario. The more common one is one-way obstruction with good inflow but poor outflow. And you'll see that a lot. And the commonest cause of that is constipation. So if you become a PD doctor, you also become an expert on poop. And you all know that PD stands for poop daily. So it's really important to avoid constipation, especially in that very vulnerable period right after the PD catheter has been inserted. Other causes of one-way obstruction includes catheters flipping up into one of the upper quadrants or into like a adhesion or some sort of pocket defined by adhesions, omental wrap or fallopian tube wrap. So it's very important to be careful about bowel cleanout, and we end up like giving these people tons of cathartics if they're having a temperamental outflow. If you can do a radiologic or even better, a laparoscopic manipulation of the catheter if it's in the wrong place or kinked or something like that, or surgical removal of omentum or omentopexy, or if it's a fallopian tube, getting the fallopian tube off the catheter. So this is from John Crabtree. This is a laparoscopic view. This is a coiled PD catheter right here, the white, and this is all omentum, which has wrapped itself around the PD catheter. And back to Ms. Karma, you can see that the catheter, which should be down in here in the pelvis, is up here. And there's lots and lots of stool. So we thought that the reason the catheter was having outflow problem had to do with all that stool in her belly, and it was pushing the catheter out of the pelvis. So she's given lactulose and a tap water enema, and the nurse tells you that there's good results. Are you happy with this? And the answer should be, well, not necessarily. One bowel movement may just empty the rectum, and there may be 15 bowel movements lined up behind it. So you never know until you recheck and see if it's working any better and get another abdominal radiograph. Sometimes even after so-called good results, there's still tons and tons of stool in the bowel. Okay, so she's sent home on the weekend with lots of cathartics and she has tons of pooping, but there's still no improvement in the outflow. You can do a catheter dye study where you inject enough dye to fill the catheter. Again, this has to be done under sterile conditions, and you can diagnose a kink in the catheter, like I showed you a couple of slides back, obstruction within the lumen, or peritoneal compartment problem. So here's the dye that's gone through the catheter, and this dye should spread out through the whole peritoneal cavity, but you can see that it's in a pocket here, and that is because of adhesions. And unfortunately, the PD catheter was put into a little pocket of the peritoneal cavity, so the PD is never going to function very successfully that way. So poor Miss Karma, none of these studies were diagnostic. She really wanted to persevere with PD. And so she underwent laparoscopic visualization. And what this is the fallopian tube. So the fallopian tube has caught on to the intraperitoneal portion of the peritoneal catheter and has stopped the outflow. So laparoscopically, this fallopian tube was released from the peritoneal catheter, and then it worked fine after that. So after insertion, remember, figure out, are we dealing with one-way obstruction, which is good inflow but poor outflow, or two-way obstruction, because they've got different causes. If it's two-way, we talked about what to do about that, suck and flush, things like that, catheter dye study. If it's one-way, the likeliest thing is that there's lots of stool and you need to work at cleaning out the patient. So clean out the bowels, recheck the catheter. If no improvement, get another flat plate. If the catheter's in the right place, it still may be an omental wrap, or it may be that the tip is in another subcompartment, and make sure that there's no more stool. I like to proceed to diagnostic laparoscopy because you can sort of settle everything with one procedure. But of course, it's another operation for the patient. I just want to touch on painful inflow and outflow, just to say that both of these can usually be treated with tidal PD. And again, let me tell you, when I troll that PD Facebook site, so many patients are complaining of painful inflow and outflow, and no one has ever suggested to them to use tidal PD. And that can be so helpful. So, in other words, if you have a 2 liter exchange, but instead of going 2 liters in, 2 liters out, the first infusion is 2 liters, but then you only drain out 1.7 liters. So that leaves you with a residual volume. And do the same thing, work with the 1.7, leaving all the time a residual volume. And that is enormously helpful for inflow and outflow pain. And in fact, in some patients who have a lot of pain, you don't want them to get into this idea that every time they go on PD, it's going to hurt. That is not what should happen. So I will even do 50% tidal, where I'll put in, let's say, 1.5 liters and do 50% tidal with 750 in and out. So there's no tugging on the bowel or anything like that, just until they get off this pain cycle. And then gradually over time, you can what we call untidal the patient and make it more closer to like a full infusion or full drain. But some of our patients are still on like 10 to 20% tidal because they're very sensitive to the inflow or the outflow. I'm going to move on to infectious complications, including exit site infection. This is a patient who grew serratia. What's the best course of action for a patient who's growing serratia on their exit site? Remove the catheter and do interim hemo for about 4 to 6 weeks. Remove the catheter and replace it with a new catheter at the same OR. Change the exit site ointment, which was, I think, mupirocin, to gentamicin, or change it to fluconazole. And I think rather than going for a new catheter right away, that it warrants a trial of therapy. So I would change the exit site ointment to one that serratia is sensitive to, which is gentamicin. So how do we prevent exit site infection? Regular application of antibiotic ointment at the PD catheter exit site is associated with a significant reduction in exit site infection and in some studies, peritonitis. What isn't known is whether the patients will develop antibiotic resistance, whether the ointment or the cream can affect the integrity of the PD catheter. And we've had some patients who have been on PD and using exit site ointment for about 10 years, and they do develop some deterioration in the integrity of the PD catheter right at the point where it meets the skin, and also overgrowth of fungus. So this is one of my patients who was on mupirocin, developed a serratia exit site infection. So I very cleverly changed her from mupirocin to gentamicin, and it got rid of the serratia exit site infection, but she ended up with a yeast exit site infection from the gentamicin. We don't see it with mupirocin for some reason, but we do with other antibiotics. But it's not as awful as it sounds. We just stopped the gentamicin. We gave her some canestin, which is an antifungal cream, and it all disappeared. Okay, here's a patient, a diabetic who had 3 episodes of bacterial peritonitis and then presented, so he got lots and lots of antibiotics, and now he comes back with another peritonitis, but this time it's growing Candida parasilosis. So fungal peritonitis is a serious complication. It's not very common, but because it's treated with catheter removal, it leads to technique failure in a lot of people. Although we have been able to put about a third of our patients who had fungal peritonitis and had their catheter removed, we were able to successfully return them to peritoneal dialysis after a couple of months of hemodialysis. It also is associated with a high mortality rate. I don't think because the fungal peritonitis is such a horrible peritonitis, but it tends to occur in very frail patients. And I think that the mortality is more related to the frailty of the patients who tend to get fungal peritonitis more than anything else. So the risk factors for fungal peritonitis far and away is antibiotic therapy. Other risk factors are immunosuppression, a peritoneal vaginal communication, and the use of J tubes, which again is the question I only get in the United States. It seems like everybody has J tubes in the United States, but that is also a very significant risk factor for fungal peritonitis. So this is supposed to be a loop of bowel, and in health, there's this normal, peaceful coexistence between fungi and bacteria. And then if you add antibiotics to the mixture, either treating any kind of infection or peritonitis, you kill off the bacteria and you get fungal overgrowth of the intestine. And somehow from this fungal overgrowth, it will leak out into the peritoneal cavity and lead to a fungal peritonitis. And that's at least my theory as to why antibiotic therapy is a principal risk factor for fungal peritonitis in PD patients. So that is why when a patient is going to have protracted antibiotic therapy, we will treat them with fungal prophylaxis. Some people use fluconazole. We use oral nystatin. You don't have to swish, you just have to swallow. But like I said, some people also use fluconazole. I don't like using it because of the risk of drug interactions with the fluconazole. So, if the patient does get fungal peritonitis, you should remove the catheter. Even if you think they're getting better, they're going to get worse again. So you have to remove the catheter and put them on at least interim hemodialysis. And no one knows how long they should be on interim hemodialysis, but we usually do a couple of months. And as I mentioned before, about a third of our patients were successfully returned to PD. Either some just wanted to stay on hemo, or really we thought they were too sick to come back to PD. But a lot of people who go on hemo hate the hemo and they want to come back to PD as soon as possible. So just keep that in mind. Poor Miss Karma has her procedure for her fallopian tube wrap. She does great on PD. She's on the transplant waiting list, but unfortunately, 3 days later, she calls and complains of progressive shortness of breath. There's no cough, no fever or sputum, no infective symptoms, but someone orders a chest x-ray, and here's her chest x-ray. And of course, you see a massive right-sided pleural effusion. And this is PD hydrothorax, which is the movement of peritoneal dialysis fluid from the pleural cavity into the pleural cavity from the peritoneal cavity, probably under a pressure gradient. This is not directional. People think, oh, well, the patient should sit up or not lie down because that'll make the fluid move more easily from the peritoneal into the pleural space. I don't think so. I think this is pressure driven. So in fact, lying down is the best because the intra-abdominal pressure is the lowest when the patient is in the supine position. Okay, so it may be asymptomatic. We've had patients who've gone for other procedures where we've just incidentally found a right-sided pleural effusion, or like poor Ms. Karma, they may present with shortness of breath, sometimes diminished effluent return, and an almost always right-sided pleural effusion on chest x-ray. Just like hepatic hydrothorax, it's usually right-sided. It's theorized that maybe the heart protects any egress of fluid across the diaphragm on the left side, and that's why it's got a predisposition for the right side. So thoracentesis can be important for relief of symptoms if they're very short of breath, and you can send the fluid for diagnosis. So of course it should be a transudate, it shouldn't be pussy, it shouldn't be bloody, it should essentially be PD fluid. And the fluid may have a very high glucose concentration, but the glucose probably diffuses out of the pleural cavity over time, just like it does out of the peritoneal cavity. So if you wait a day or something to get the pleural fluid, the glucose concentration may not be very high because the glucose from the dialysate has diffused out of the pleural space. And don't use intraperitoneal methylene blue. You'll see that on some of the on some of the old papers, they say to put methylene blue into the PD fluid, put it into the patient, then after a while sample the pleural fluid, and if it's blue, then you know that you've got a connection between the two cavities. But in fact, that's not necessary, and the methylene blue is a chemical irritant and will really hurt. So really imaging is the best way to do this. And of course, sometimes we've had patients who didn't have a pleural effusion. They start on PD. The next day they have a massive pleural effusion. We bring them into hospital. We stop PD and it goes away like right away. And then you really have your diagnosis. And I think that really in that case, you really don't have to do imaging because the diagnosis has spoken for itself. So if you have a peritoneal pleural communication, which is usually due to some defects in the hemidiaphragm, then that's what is felt to be what causes the movement of the dialysate fluid under pressure from the peritoneal to the pleural compartments. So what do you do about that? I talk to the patient. Okay, you have to stop PD and then have a talk with the patient about returning to PD. If the patient wants to persevere with PD, you have to do something to block up this communication between the two cavities. And this is usually done by pleurodesis. Or the newer thoracic surgeons like the idea of doing VATS, identifying the defect and doing a repair. But the problem is that some of these defects are microscopic. And because they're microscopic, you can't see them on VATS. And the other thing is that the movement of the fluid from the peritoneal to the pleural cavities occurs way more slowly. It happens like over many hours, not right away. If you had a big defect in your diaphragm, then it might occur right away. But if it's microscopic defects, it takes a while for it to occur. So just keep that in mind. If the patient says, forget it, this is like just all too much, I want to do hemo, then, maybe they should go to hemo. But if they do want to persevere with peritoneal dialysis, you will have to speak to your thoracic surgeon about doing something like a pleurodesis to close up this defect. What we do after pleurodesis is that we leave them for, again, at least a month, and then we will bring them in and re-challenge them with PD in the PD unit and see if that works. Now, that will be good for the few hours that they're in the PD unit. But again, like I said, if they're microscopic defects and the pleurodesis hasn't worked, then it may accumulate over days. So you've got to keep an eye on these patients. Okay, peritonitis. 4 years later, she develops peritonitis. Which one of the following is true? She didn't have fever, so therefore, given that she didn't have fever, the abdominal pain she's got is likely not due to PD peritonitis. Is that true? Typical PD peritonitis rates average about 1 episode a year. There's approximately a 20% risk of systemic bacteremia from PD peritonitis, and empiric coverage should be given for both gram-positive and gram-negative organisms until you have identification. So if you see that on an exam, think about what you think the best answer should be. So the diagnosis requires at least 2 of the following 3 features: leukocytosis of the PD fluid with at least 50% polys. This should be after the fluid has dwelled for at least 2 hours, ideally for 4 hours, but at least for 2 hours. Abdominal pain and positive culture of the dialysate effluents. You see that gram stain is not part of these 3 features. And of course, you're not going to get the positive culture of the effluent right away, but it's important that the ISPD has agreed on this diagnosis because then I can compare my peritonitis rate to your peritonitis rate if we're all using the same criteria for the diagnosis of PD peritonitis. Now, hematogenous seeding, this is a very important and misunderstood point. Bacteremia from another cause. Bacteremia can seed the peritoneal cavity and is a rare cause of PD peritonitis. Okay, so bacteremia from some other cause can seed and cause bacterial peritonitis. However, Peritonitis is the primary event, hardly ever. I would say never, except I know you can never say never, but peritonitis doesn't lead to bacteremia. And people seem to have that backwards. And I've had like CV surgery people who say they're putting in a mechanical heart valve, so the patient should be on hemo and not PD because I don't want them to get peritonitis. And it's actually the opposite is true. With hemodialysis, if they get infection, it's bacteremia, and they're going to seed their valve, or they may seed their valve. Whereas peritonitis, even if they get a nasty peritonitis, they are not going to develop bacteremia, so you're not going to worry about them seeding their valve or their LVAD or anything, or their prosthetic hip or anything like that. So while I think any patient should have a choice between PD and hemo, if they have hardware in their body, I really think that they should be encouraged to do PD, because even if they get peritonitis, they're not going to get bacteremia. And also, because of the risk of bacteremia, we use antibiotic prophylaxis at the time of anticipated bacteremia, including dental work, endoscopy for sure, and these other procedures that you can see here. And the fluid should be drained before they undergo these procedures. Now, the most recent iteration of the ISPD guidelines for prevention of peritonitis do no longer say to give amoxicillin 1 hour before dental work, but we still do it. So the principles of treatment of peritonitis is to start antibiotic treatment as fast as you can. There's a principle in general ID that the sooner you start antibiotics, the better the outcome, and that goes for PD peritonitis too. A cover for both gram-positive and gram-negative organisms until the cultures are available. And don't use the gram stain to decide what antibiotics to use. So adjust the antibiotics once you get back the culture results, which is usually like in 24, 48 hours, and then evaluate if there's any improvement, including a reduction in pain and a falling peritoneal fluid white cell count. And I know I've made the mistake of just judging by how cloudy the fluid is. And I think you can't do that, because I think you're hoping for it to get better. And I think it sort of affected my judgment. And I thought that the fluid was becoming less cloudy. And that's why you really need like a real marker, like the PD fluid cell count, which you should see falling regularly if it's being treated successfully. So consider removal of the PD catheter if there's little or no improvement in 4 or 5 days, especially if the causative organism is Staph aureus or Pseudomonas, because we know that those are bad players. They tend to glom onto the intraperitoneal portion of the PD catheter, and they just don't go away. And so you should have a lower threshold for removing the catheter if nothing's getting better, or even more so if things are getting worse in the first 4 or 5 days. And as I mentioned before, if it's fungal peritonitis, remove the catheter as soon as possible. Don't let peritonitis drag on for days. It's a very pro-inflammatory condition. And if you try one antibiotic and they're not getting better, and they say, okay, let's try a different one, let's try this, well, let's try that. And meanwhile, it's like 10 days and the patient is just going downhill. So it's very catabolic. And so you should make a decision after, I believe, 4 or 5 days about whether you're going to remove the PD catheter or not. And don't forget the guidelines, okay? Anybody can go to the ISPD.org guidelines. There's a section there on guidelines, and you will find how to treat these. So if you have a patient who's got like an unusual organism causing peritonitis, or they've got drug allergy or things like that, there's all these tables in this guideline that can help you to adjust your antibiotic therapy. I just want to say a word about Pseudomonas peritonitis. It's kind of standard of therapy to combine 2 anti-pseudomonal antibiotics for 21 days. There really isn't a whole lot of good evidence for that, but that's what we do. If Pseudomonas peritonitis is in association with a Pseudomonas exit site infection, then you know that the whole shebang is infected with Pseudomonas and it's not going to get better, and you should remove the catheter. But I want to show you this slide because this is not really well appreciated. If you have just a Pseudomonas exit site infection, or if you have just a Pseudomonas peritonitis, it's worth a trial of therapy because sometimes they will get better. It's when you've got both that you know that it's all colonized, and that's when you should remove the catheter. So please keep that in mind. People think for some reason that just because someone gets a Pseudomonas peritonitis that the catheter has to come out like fungal peritonitis, but that's not true. A significant proportion of them will get better with the appropriate therapy. It's just when you have both together that you should take out the catheter. So the best answer here was that empiric coverage should be given for both gram-positive and gram-negative organisms. Fever is present in about 50% of patients, so lack of fever does not rule out peritonitis. Most units will have peritonitis rates of about 1 episode every 36 months minimum. Our rate for the last 5 years has been about 1 every 60 to 70 months, or in other words, 1 episode of peritonitis every 5 to 6 years. And like I told you, PD peritonitis doesn't lead to bacteremia, so that's really important if you have someone with, like I said, a mechanical heart valve or an LVAD or something like that. And this is an interesting study. This looks at risk for technique failure, which means a permanent transition to hemodialysis after peritonitis. And this was an Australia-New Zealand study. But what it showed was the only thing that really strongly predicted that someone was going to switch to hemodialysis was the center-specific characteristics, not so much any other cell count or patient-specific characteristics or anything, which suggests for many people that centers that don't really trust PD or aren't comfortable with PD or don't have a lot of PD patients are very quick if a PD patient presents with peritonitis just to stop PD and switch them to hemodialysis, which is perhaps not the best way to go. Okay. Non-infectious complications. This is a man with PKD who you can see his prescription. 1 year later, he's doing great. He still has a residual kidney function, and it looks like his wife is going to be accepted to donate a kidney to him. True story, he works as a building superintendent, and he was crouched under someone's sink trying to fix a pipe, and he felt a pop, and then he had some tenderness in his groin, and you can see that there is now a left inguinal hernia. You can see the fullness here compared to over on the other side. So peritoneal dialysis does increase the intra-abdominal pressure, and just how much it goes up depends on how much fluid you put in, the position of the patient, with the lowest intra-abdominal pressure in the supine position, neck standing, and the highest in the sitting position. High older age and higher body mass index raise the intra-abdominal pressure. And then things that our patients do, like straining at stool. I had a patient who filled himself up with fluid and then decided to go out and chop wood and ended up popping a hernia. So all of these can raise the intra-abdominal pressure. So again, this is just a nice little schema. Here's the volume of dialysis fluid on the x-axis, the intra-abdominal pressure on the y-axis, just to say that the more volume you put in, the higher the intra-abdominal pressure, but this is mitigated by the position of the patient with the lowest pressure in the supine position. This can lead to hernia. So here you can see a couple of ventral hernias. Here's an umbilical hernia, and this one is the biggest risk for incarceration. So the majority of incarcerated hernias occur with an umbilical hernia because it's got that small fibrous ring at the base of the umbilical hernia. And if the bowel gets into there, it will it will get caught. Whereas if someone's got a big ventral hernia, the bowel can sort of float into the hernial sac and float out again, but it can get caught in an umbilical hernia. Here's an inguinal hernia from the side. You can see it popping out there. So warn patients with a hernia about signs of incarceration. So I say you should be able to push it back in. If you can't push it back in and it hurts, then you need to go to the emergency department. And in fact, just a couple of days ago, one of our patients with a little umbilical hernia, it started to jut out and it really, really hurt. And he went to the hospital and he had an incarcerated hernia. So surgical repair is warranted. Most people want surgical repair. Of course, it's unsightly. It's a risk of herniation. Now, you don't automatically have to put someone with a surgical repair of a hernia onto hemodialysis. So what we do, if they have a decent amount of residual kidney function and they're a stable patient, is that we will just stop their peritoneal dialysis on the morning of the OR, let them have their surgical repair of the hernia, leave them dry for a day or two, and then just slowly reintroduce PD under conditions of low intra-abdominal pressure, which means small volumes in the supine position. The only exception to this, where maybe it would be a good idea to put them on interim hemodialysis, if there is serious bowel incarceration and strangulation, you're now putting a damaged loop of bowel back into the peritoneal cavity, and that can lead to enteric PD peritonitis. So in that case, I would either rest them for PD either with interim hemo or no PD if they've got a lot of residual kidney function for the better part of a week, monitoring them very closely. The other place where maybe you want to do interim hemodialysis would be if they have no residual kidney function. But again, I think this is a patient by patient decision, but don't think that you have to, if you're repairing a hernia in a PD patient, automatically have to switch them to hemodialysis for this. And if their surgeon says that to you, again, there's literature in the surgery literature showing that you can do this without transitioning them to hemodialysis. So what happened to our superintendent? He was switched to night cycler dialysis in the supine position and dry during the day when he was active and bending over and raising his intra-abdominal pressure. He underwent an elective hernia repair, no PD for 2 days. Then we put him back on night cycler and then didn't introduce a day dwell because he had continuing good residual kidney function. So keep that in mind. You can finesse these people without hemo. Abdominal wall or genital edema is leak of the dialysis fluid out of the peritoneal cavity, and it can lead to subcutaneous edema, genital edema, diminished effluent return, weight gain without peripheral edema, and a leak right at the insertion of the catheter can lead to wetness or swelling at the exit site itself. So this is peau d'orange or orange skin in someone with diffuse leak of PD fluid into the subcutaneous tissue. You can see that sort of poofy appearance of the skin, which is subcutaneous edema. And we have moved the catheter that was sitting there to the side, and you can see the indentation where the catheter was sitting. Sometimes you see the indentation of the elastic from underwear and so on. Here's another patient with abdominal leak. Here, the break was through an umbilical hernia. But again, you can see the poofiness of the skin, and you can see where the catheter was sitting there, the subcutaneous edema. And here's more subcutaneous edema. You can see this big ventral hernia, and it's a source of leak of dialysate into the subcutaneous tissue. And you can see the leak there. So CT scan can be helpful. I mean, like in that last patient I showed you, it's pretty clear where the leak was coming from, but you can do a CT scan. You add radioligand to the dialysate bag, infuse it into the patient. Then you've got to do something to make sure that the patient raises their intra-abdominal pressure. So the reason you get false negatives in these studies is that someone just has the patient lie quietly on a stretcher. You put in the dialysis fluid with the radio contrast, but they haven't done anything to raise their intra-abdominal pressure, so it's not going to leak anywhere. Or even worse, they put in the 150 mils of radio contrast without any dialysis fluid, and it just sits like a little puddle in the middle of the peritoneal cavity. It's not going to show you anything because it's not going to go anywhere. So it's important then you do this to raise the intra-abdominal pressure to have it leak where it's leaking. And if you're in a place where they don't do a lot of PD, it's important to discuss with the radiologist and have a look at it yourself. So this is a CT scan with intraperitoneal contrast in a young man who presented with scrotal edema. And you can see the bright white, which is leaking through the patent processus vaginalis into the tunica vaginalis on both sides. So it's giving like a hydrocele, but it's made up of dialysis fluid because it's labeled white. And here's leak of dialysate out of the peritoneal cavity. This is the dialysis fluid in the peritoneal cavity, and you can see that it's exiting the peritoneal cavity right there and going into the subcutaneous tissues. And what you can see here is perhaps subcutaneous edema from a previous leak of dialysis fluid before you put the radio contrast in. So there's two pathways to genital edema. One is a patent processus vaginalis, which connects the peritoneal cavity to the tunica vaginalis. And in some people, this is just open, men more than women. And therefore, with the installation of the peritoneal fluid, that goes right away into the tunica vaginalis, and they end up with a hydrocele. A more complicated one is if there's a break in the peritoneal cavity somewhere here, and the fluid is leaking out of the peritoneal cavity into the subcutaneous tissue, which can lead to penile edema or edema of the scrotal wall. So there's two different tracks by which PD fluid can get into the genitalia. So this is pressure driven. So reintroduce low pressure PD, APD with low volumes in the supine position, or temporary hemo to allow healing. You can do a CT scan looking for occult hernia. Sometimes patients who are very obese do have a hernia, but you can't really see it on physical examination. And for genital, the CT scan is very helpful for looking for patent processus vaginalis, which is easily repaired surgically. Okay. Finally, SV and her scary episode. This is a young woman who lost her period, and it turned out that the cause of her losing her period was that she had undiagnosed advanced chronic kidney disease. She did pre-dialysis education and started on peritoneal dialysis. And she was doing great on PD, and her periods came back, which I always take as like a really good sign. But with her second period, she had painless, bloody effluent called hemoperitoneum. And she was all scared, and it looked like 2 liters of blood. And she went to the ER, which is like the movie Carrie, where everyone panicked and thought she was having a major bleed. And they did all this urgent blood work. So this is hemoperitoneum. There's benign causes for it. The commonest cause of hemoperitoneum is happily a benign cause, which is menstruation. And menstruation can either be by retrograde menstruation, like from the uterus out of the fallopian tubes, or by endometriosis. I'll come to that in a minute. Sometimes ovulation, when the egg breaks, will cause a little bit of ovarian bleeding. And so people may get mid-cycle hemoperitoneum. Ruptured renal or ovarian cysts, even though the renal cysts are retroperitoneal, it can rupture through the peritoneal membrane and lead to hemoperitoneum, trauma, and coagulopathy. And Dr. Tucker will remember a patient of his who was like in his 70s and had to quote Dr. Tucker, I think, vigorous sexual intercourse, and the next day had hemoperitoneum. So menstruation itself leads to bloody effluent by retrograde uterine bleeding or by endometrial studding. But there are serious causes of hemoperitoneum, and although it seems even though it seems counterintuitive, if you do have a PD patient who presents with hemoperitoneum and they haven't had vigorous intercourse and they're not having their period, or they're a non-menstruating woman, it's worthwhile to do an investigation because it could be the first sign of something like a colon cancer or something like that. So IP heparin to avoid clotting of the catheter, flushes until it's clear. If it's active bleeding, you can use unwarmed dialysate to try to cause vasospasm and stop the bleeding, and then decide if this is benign or a serious type of presentation. And finally, what do you think about this? This is not cloudy PD fluid. This is milky white PD fluid. This is chylomperitoneum, which is very rare. It is not PD peritonitis, and it's got a large differential diagnosis, including calcium channel blockers, a traumatic rupture of a lymphatic trunk during insertion of a PD catheter, lymphoma, and so on. So what have we learned? Constipation is the number one cause of a one-way obstruction. Having a bowel movement doesn't mean it's better. Think of hydrothorax if a patient gets short of breath early in the course of PD. Patients usually start PD as an elective. They usually have decent urine volume. It's unusual for a patient to get short of breath right away, and you should think about hydrothorax in that setting. Long-term antibiotics are a risk for fungal peritonitis, so we use fungal prophylaxis. I think it's a bit of a pain, but it's low-risk therapy, and fungal peritonitis mandates like a big deal. Staph aureus or Pseudomonas infection of both the exit site and the PD catheter are not going to get permanently cured with antibiotics, so unfortunately the catheter has to come out. And finally, the commonest cause of hemoperitoneum is the menses and needs no further investigation in this setting. And hernias are common in PD patients. About 20% of PD patients in some studies will end up with a hernia. If you have at-risk patients who are heavy or have had previous hernias or have polycystic kidney disease, keep that in mind and try to give a low-pressure PD prescription. Hernias are unsightly and usually patients want to get them fixed. They can usually be repaired operatively without switching to hemodialysis. Hernias may lead to secondary bowel incarceration and strangulation, and they can be a source of a break in the integrity of the PD cavity, leading to leak of PD fluid into the surrounding tissues. And again, I have some references for you, including that and clinical trials, and I'm happy to answer any questions. Thank you.
Thank you, Dr. Bergman.